Good afternoon. We're going to go ahead and get started. My name is Janelle Gagne. I'm one of the planning committee members for the CRN track this year. So without further ado, I'm going to introduce our dynamic team up here. They're going to be kind of tag teaming, so I'm not honestly sure who's going to speak first. Chris is, okay. So we'll start with Chris for introductions. Chris Nelms has over 20 years of dietetic experience specializing in pediatric kidney disease. She's held several clinical positions, most notably at Children's Mercy, and also educates and trains in this niche specialty as well as providing private care. She's involved in research, has numerous publications, and presents at local, regional, national, and international meetings. She is a member of the International Pediatric Renal Nutrition Task Force, whose primary goal is formulating clinical practice recommendations. She is very involved with the Pediatric Renal Dietitians of North America, the first professional practice group aimed at serving as a leading source of pediatric renal nutrition expertise. She is currently pursuing her doctorate at Rutgers University. Next, we have Molly Vega. She's a registered dietitian who is a board-certified specialist in pediatrics and sports dietetics. For the past 15 years, she has worked for the renal service at Texas Children's Hospital. She is active in research in critical care nephrology and pediatric malnutrition. She is a committee member for the National Pediatric Malnutrition Work Group of the Academy of Nutrition and Dietetics, is on the board of editors for the Pediatric Nutrition Care Manual, and a member of the International Pediatric Renal Nutrition Task Force. She recently completed her doctorate in kinesiology with emphasis in exercise physiology at the University of Houston, researching the role of physical activity in children with chronic kidney disease. Please help me welcome our speakers to speak on vitamin mineral needs.
Thank you for the introductions, Janelle, and thank you for allowing us to speak on this topic. Thank you, NKF. So we have no official disclosures, but the one kind of personal disclosure I wanted to make is, yes, Molly and I both work in pediatrics, but our goal, and the reason we're here today is because we are part of the Pediatric Renal Nutrition Task Force that is developing clinical practice recommendations for care of children with kidney disease worldwide, and we were on the vitamin and mineral teams. But our goal today is actually more about critical thinking about vitamins and minerals. And so we're going to walk you through a little bit about how we came up with, or our team came up with the recommendations, but we're going to do a lot of comparisons to the 2020 KDOQI guidelines. And really our goal is for pediatric or adult clinicians to think through what evidence there is out there and how we critically think about making vitamin and mineral decisions for our patients. So with that said, our goal is to apply literature that supports clinical practice recommendations, solve some clinical quandaries with interactive case studies, and I guess my other disclaimer is you will want to have your phone with the app ready throughout this talk because we have tons of interactive pieces. We really want you all to be part of this and to be critically thinking along with us. So be ready to go. And then we are going to talk a little bit about the differences between adults and peds because part of a paper that I published recently showed that even adult clinicians, about half of you, actually slightly more than half of you, do end up working with a pediatric patient at some point in your career. So the one-off pediatric patient you do get, you'll be ready. Okay, so let it start with a poll. Do you assess your patient's micronutrient status? Okay, just in the interest of time, I'm going to give this about 15 more seconds. This is really just to get you thinking about your involvement with vitamin and mineral needs. So the answer is yes for most of you, 76% right now. And I think that we do assess our vitamin mineral status in a lot of patients, even if we don't do it maybe formally through biochemical evaluation. And we're going to talk about that a little bit more. So my next poll question for you is, for dialysis patients, which micronutrients are you most concerned about? Okay, so we're seeing magnesium. That's interesting. Zinc. I would agree that's a biggie. B vitamins. Okay, so I'm gonna, while it keeps coming in, I'm gonna just note that what I'm seeing here is most of the micronutrients. And I think, of course, potassium and phosphorus, vitamin D, those are things that we are huge to our practice. And that's actually not the focus of today's talk. It's more the micronutrients. But those are the things we have to think about all the time. But really, are we concerned about some of these others along the way, and how do we think about that? So CKD patients, what micronutrients are you most concerned about? Sodium and iron. I know in my dialysis patients, we worry a lot less about, or for CKD patients, we worry a lot less about some of these things because we know we're not losing them. Vitamin D, a lot of recent information on vitamin D. Calcium, zinc, iron. Always a great quandary. Do the dietitians think more about the iron, or do we leave that up to the doctors? Okay. Again, we're not maybe seeing quite the diversity of answers as with dialysis, and I think that's reflective of the fact that we do worry more about our dialysis patients and those losses. So moving on, we're going to talk now about some gaps and implications in our guidance. And one of those gaps is familiarity with guidelines. If you look at the 2020 KDOQI guidelines, I mean, raise of hands, who here has read those cover to cover? Okay, yeah, Desiree, I'm not surprised. Janelle, I'm not surprised. But honestly, the regular dietitian day to day does not have time. I know that when I need to get to the quick of things really quick, I'm looking at bullet points. Challenges in tailoring interventions to individual patient needs. We have a very diverse population from, depending on where you work, you could work with kidney stones or transplant or dialysis, but even among the dialysis unit, we have PD and hemo, and they act very differently. Differences in nutrient needs, so even if you are strictly an adult clinician, our elderly are a lot different than our younger adults, and then we really don't know much about the impact of our clinical judgment. There's not a lot of studies that say, okay, you supplement and then this happens. So what I'm going to do now is talk a little bit about how our team that Molly and I have been part of developed, in this case it was clinical practice points. Clinical practice recommendations is the term that was used for some of our bigger recommendation papers that have come out. But honestly and frankly, because there is not great literature in vitamins and minerals, we had to sort of downgrade the title of this to practice points because we had to use what we had. So now I know y'all just had an update in 2020 if you work in the adult world, but in the pediatric world, the last guidelines from KDOQI came out technically in 2009, but they were the 2008 update. And KDOQI is a massive amount of work. From my understanding, it's about $250,000, probably more by now, to put out a KDOQI guideline. It involves extra people that review or even screen the literature to take it to the decision makers. And so a massive amount of work went into that. So the task force took the approach of let's take the baseline work that went all the way back to, the 60s and 70s when we were even first getting literature in renal nutrition, and then built on that. But what the task force realized is that by 2017, when the task force started, really the literature ended about 2006, because it takes that long to publish a KDOQI. And we realized that we needed something to update things. So the goal was to use KDOQI as a foundation, but topic by topic to update from them. So we also wanted a global approach because at least our KDOQI was pretty North American centric. And so actually supported by ESPEN, the European Society of Pediatric Nephrology, there was this task force created, and they included clinicians from around the world. And Molly and I were fortunate to be among North Americans that represented. The goal is then to also update guidelines, if there are any updates, to happen every 5 years to stay on top of things, so we don't end up like a situation like the 2008 KDOQI that hadn't been updated. So I'm not going to belabor some of these points, but just there's a group of clinicians that came together from Europe and North America, and as you'll see on this slide, we diversified. Forgive me for this is a borrowed slide and I didn't know how to make it fancy, so poor Australia's in black there, but we added an Australian clinician recently. And the key thing I think that the task force feels that we've done our due diligence on is that we have Delphi reviewers from truly around the world to say yay or nay, this is really truly evidence-based practice. So the task force is to ensure best practice in children with kidney disease, and then promote not only best practice, but we do a lot with dissemination work and education and making sure that resources are needed. I think one difference with the task force is we create lots of patient and clinician resources. So the development process, and I wanted to highlight this just to highlight how we think about the development of practice guidelines. So we use the PICO format, which if you do much with research is a pretty common approach. Our population, of course, was under 18, whether you consider pediatric 18, 21, 25 is a little bit up for debate, but this is our cutoff. We thought about different stages of CKD compared to healthy children, and then our outcomes. We used several search engines, as well as manual searching, and we had some cutoffs. And I will importantly mention that because in this niche area we have limited data, when we had lack of data, we did extrapolate from the adult guidelines. So I feel like Molly and I have spent a lot of time also looking at adult papers over the year. So this is a busy slide, but it's just to kind of show our process. This shows our PICO questions specific to vitamins and the main questions we asked. This is an example of our tables and the different word categories we used for our literature searches. We then also looked at general vitamin and mineral needs, and because this was a global approach, we pulled together the recommendations from different governmental bodies from around the world. Of course, we brought the IOM, but the Nordic guidelines, the French guidelines, we reviewed all that to really come up with numbers that we were comparing to globally. And then this just shows kind of an example. This is the vitamin A table of the papers we looked at and our evidence tables and how we pulled that together. So our challenges and considerations, we needed to define our population. We need to consider assessment of how we considered vitamin and mineral supplementation, what our intervention was, our evidence, and then some specific areas such as CKD versus dialysis. And of course, we had to reach a 70% consensus with our Delphi reviewers. And again, I'm not going to repeat this throughout the talk. This is just to show you the structure and framework. These are the clinical questions we asked for vitamins. They're virtually the same for minerals and trace elements. We wanted a really thorough approach, not just thinking about what is important to dialysis or transplant or CKD, but cooking methods, sources, because we really actually uncovered some important information by looking at that. Again, just kind of a flow. We start with requirements, dietary sources, dietary modification. Non-dietary factors was a pretty big deal for us because, for example, there's a lot of iodine-containing medicines. There's zinc in certain products. Those were some of the considered, vitamin A, and especially topical creams, and how much of that is absorbed, and do we need to be evaluating those things? Assessment and monitoring, and then our intervention. So turning now to something you adult clinicians may be more familiar with, the KDOQI clinical questions. They are very similar to what we looked at, but primarily focused on assessment and intervention. So how do you assess micronutrient needs in the different populations, and then how do you intervene? One thing that was interesting to me is KDOQI really focused on some key vitamins and minerals, and did not include, for example, all of the minerals. With the task force, we did broaden our net a little bit. We looked at things like iodine and fluoride, and so I'm hoping that for those of you who work in adult practice, you might take a few nuggets away from what we looked at in pediatrics. But overall, the process was very similar. Okay, so how do you make practice recommendations, whether it's KDOQI, whether it's our Pediatric Renal Nutrition Task Force? Well, we look at the data, and we did look at data, and we did find some data that was supportive, but the reality is, again, there's just not a ton of literature, adult or pediatric, in our population because these studies are very difficult to do for a variety of reasons, because it's hard to get patients that are willing to do those detailed lab things. Labs are expensive. It's hard to show outcomes. So ultimately, we have to resort often to expert consensus, which is that clinicians with lots of years of experience see things over their time. And then I think one big focus of our task force is what do we take away from this practically? Based on the limited evidence that we have, can we make some true clinical practice recommendations that I can use here and now in my patients? And especially in these two areas, pediatrics for us, and just vitamin and mineral needs in general, there's a paucity, and how we had to really think clinically as well. These are our evidence tables. I'm not sure why fluoride isn't included. This is a borrowed slide. But it showed how many studies initially we came up with on our HIT. Now, keep in mind, then these were whittled down. These are just big PubMed searches, and then these were whittled down to actually fairly few actual applicable papers. We probably had the most data for zinc and magnesium, and then a lot less that we ended up using for some of these smaller vitamin and minerals. So again, just making my point, really small to varying numbers and different methodologies. So some things that we had to consider unique to our population is things like growth and development, age of onset of disease. The baby with CKD has a lot more long-term issues than an adolescent, for example, where most of the growth is done. Nutrition support use. One, I think, key difference between pediatrics and adults is we do lots and lots with enteral formulas. Our under 3 population uses a lot of enteral formulas, and I think that's a lot less common in the adult world. And so we really have to think of the impact of enteral formulas and vitamin and mineral contributions. Strategies for a spectrum of patients. So we did look at CKD through transplant, and then PD versus hemo, there's a lot of differences there, even high transporter versus low transporter. There's a reason it's hard to do these studies is because you have so many variables. And so what ultimately it boils down to is lack of evidence doesn't help me and my patient now. So I think the concern when you're making statements is that when there isn't evidence, what do you say? And I think the safe or cautious approach that goes into a lot of guidelines is to say, well, I can't really say anything because there's not enough evidence, so I'm not going to say anything. But that doesn't help me as a clinician. So I think, and you can argue whether we were right or wrong, one approach we took on the task force is to make some guidance-based statements of things, and we did, of course, have to sort of prelude with this may or may not be true, but some actual clinical practice statements that get clinicians thinking about maybe I should consider doing this. Because when we're just like, there's no evidence for B vitamin losses, that doesn't tell me what I should be thinking about clinically. So we really had to put this in a frame of reference of available resources. And I think one thing I think you'll see throughout this is because we know biochemical tests are expensive, that we, the dietitians, are key. And any non-dietitians in the room, I know other clinicians sometimes do evaluation of this as well. But the point is the clinician is the key. We are the ones assessing the diet. We are the ones looking at our patients. There was a great talk yesterday on physical exam, and we are the ones who are noticing that the fat pads on our patients are slowly sinking in. We're the ones that are noticing that our patients look different today than yesterday. And that is our starting place. Even if we don't run a zinc level on every patient, we are the ones that through our dietary evaluations and looking at our patients really can clinically consider, do we need to be thinking about these things? So another poll for you all. What is the most common assessment metric that you use to dive deeper into a patient's micronutrient status? Seeing a good variety of answers. Reported intake is a biggie. I really love that because although I think it's unrealistic to do a detailed dietary record on every patient, we can, as dietitians, we can get a good feel for what a typical intake is and then dig deeper for those patients that we're concerned about that maybe we need to do a fuller food record on. But we have a pulse, at least on what our patients are eating. We know it's cumbersome for our patients to do 3-day food records or whatnot, but I think that that's part of our developing relationship with patients as we learn some of these things, even if we don't do an official record. Lab markers, of course. I'm always looking at monthly labs, and that's important. And we can ask for biochemical evaluation if our initial, what we're seeing as a dietitian makes us think that we need to do more. So back to our development of guidelines or clinical practice points. Some framework that we had to have. Patient characteristics. Again, it's difficult to stratify by these things because there's so many variables in the CKD world, but we want to think about all the different factors, and does that make us ask some questions about micronutrient needs for one patient more than another? Dietary intake and absorption. So we should know the food sources, and a lot of that is cultural. I'll give you a little spoiler alert. One thing that we were concerned about in our task force that we kind of dug out on a global basis. Seaweed is very, very high in iodine, and you will see a statement in the clinical practice recommendations that you may need to limit seaweed because of the iodine content. For certain populations that might eat, for example, more sushi. So there's those kind of patient variables. GI losses, so another spoiler alert, we don't encourage vitamin A in most patients, but the studies that did show any patients with concerns about vitamin losses were patients who had severe GI losses, stoma, things like that, where they were really losing all their vitamins and minerals. So you need to consider those individual factors. Metabolism and clearance, and that includes the impact of CKD on metabolism. Again, that high PD transporter versus a low transporter. Clinical signs and symptoms, which I think as dietitians we're experts at noticing about our patients. Lab trends, again, I always will stand by one lab is never going to tell you anything about your patients, but the trending of labs over time is what's really going to give you the clues on your patients. Intervention strategies. So of course, our first goal is with food, and then secondary options are enteral nutrition, and even possibly parenteral nutrition, IDPN, whatnot, and then concurrent monitoring for toxicity. So turning to those KDOQI 2020 guidelines, just a bit of a comparison. Their 5.1 talks about the spectrum of CKD and that it is reasonable for the dietitian to encourage an oral intake that meets about 100% of the needs. We want nutritionally complete diets, and ideally we want to do it through food. When it comes to supplementation, it is reasonable for the dietitian to notice where the oral diet isn't meeting those nutrient needs, and in collaboration with the team, evaluate whether a supplement might be needed. Because the reality is that many of our patients, because of uremia, lack of appetite, etc., eat poorly. So then comparing that to the Pediatric Renal Nutrition Task Force guidelines, we took the approach of, again, looking at vitamin and mineral requirements, the sources of those vitamins and minerals. And I know, like, I always kind of chuckle at our 1.1.1, that's a mouthful. It says vitamin requirements may be less or greater than that for healthy children. Well, what does that say? That's, of course, it could be less or more, but there are certain vitamins that we may require more of, some we may require less of, and then as we get into the guideline statements, it talks about that more. And then how do dietary modifications affect intake? And that's to recognize that food preparation may have an impact in that. So when we're thinking about, so actually our guidelines, the only major mineral that we focused on was magnesium. The rest ended up being trace elements. And part of that is because the task force published papers specifically on phosphorus and calcium, and a different group that was commissioned by ESPEN focused on vitamin D. And so we really were focusing on, I think, what we think of as the true micronutrients when we're thinking about renal patients, because the others are sort of special categories of their own. And so we basically replicated those statements with our magnesium and trace element paper. And again, thinking about food preservation methods. We then looked at non-dietary factors that influence vitamin and mineral intake, and I mentioned those medications and some of these other renal factors. And then how do we approach clinical assessment and monitoring? And I think that a theme you're going to be hearing kind of repeatedly from Molly and I is that we start with knowing what they're eating. We start by looking at our patients. We start by clinically evaluating our patients. And then we move on to the more invasive things like labs, or getting our team involved for supplementation or whatnot. Physical evaluation is important. And then we specifically state routine biochemical assessment is not indicated. Does that mean you can't do it? My unit regularly assesses the zinc level every 6 months because that's been something we've found that is low in a lot of our patients. So it's not to say that you can't do it, but keeping in mind that this was a global guideline and that a lot of facilities and countries around the world don't maybe have realistic means to do all of that, that we need to have that only if the evidence is there as a statement of, yes, you should do this. Again, very reflective with the magnesium and trace element that we want to be thinking about non-dietary factors and that routine biochemical assessment is not considered and that we really need to be considering physical and dietary evaluation. So then we moved on to when is intervention considered. And of course, our goal is to optimize nutritional intake and then consider supplements. And for us, we use a lot of enteral formulas and oral nutrition supplements. So now we're going to move to a case study. So have those phones ready because we're going to be walking through these. I apologize that we have a slant toward pediatric case studies. It's because they're often based off patients we've had, but I think a lot of these patient examples you could extrapolate to adults very easily. So in this case, I have an 8-year-old with a complex medical history, and I'll mention we have kind of a variety of case studies, inpatient dialysis, CKD, with developmental delays, rare genetic condition, has stage 3 CKD as a comorbidity from their overall medical picture. So they were admitted inpatient for respiratory failure and community-acquired pneumonia, developed mild AKI, didn't need renal replacement therapy, but when they were transferred out of the ICU to the floor, calcium and ionized calcium really trend up, reaching a very high level of 12.2. Sometimes our lab ranges are a little higher in pediatrics for calcium and phosphorus because of growth, but this is high even for a pediatric patient, but their phosphorus was normal. So, this is really just a clinical judgment question. What steps would you consider evaluating this patient? And again, some of these questions you could probably take in more than one approach, but I'll explain the approach that ended up working for us. So we have check magnesium level, PTH level, check PTH level, retinol level, refer for a DEXA, start phosphorus binders. Can I give it just 15 more seconds? Okay, things are slowing down. So I am gonna say I am not gonna criticize anybody who picked A, because actually probably we did draw a magnesium level, but what was actually helpful to us was drawing a PTH level and a serum retinol level. What we found was that the PTH was high normal, but the retinol level was elevated. And I'll tell you why we checked this. What steps would you consider for treating this patient? Start phosphorus binders, stop formula. They were on an enteral formula because they were really sick upon admission and not eating. Stop formula and start TPN, or start bisphosphonates. Okay, and I'm sure our last poll kind of gave away the answer. We did switch to a low vitamin A formula. And interesting later on, because the calcium was a little refractory, the physician did need to do some bisphosphonates actually, but we switched him to a low vitamin A formula. So this is going to lead us into our discussion of fat-soluble vitamins. So another step back that I wanted to take is to talk about how we think about our vitamin and mineral recommendations for a general population. And I picked vitamin A only because it was the first vitamin we were talking about. If we look at the IOM and how they came up with their DRIs. Keep in mind, the DRIs are broad. There's adequate intake, there's the EAR, there's upper limits, and so I think vitamin A, more than most of the other vitamins, had a lot of different angles to cover. And they weren't looking at any specific disease state, but they considered, vitamin A in pregnancy, the teratogenic effects. So there's a lot to cover in vitamin A, more than some other topics. They found that it was very difficult to extrapolate to all ages and genders. There was a lot of in vitro and animal data that they used to develop our DRIs for all the vitamins and minerals. And so, as I mentioned, there was an RDA, EAR, and upper limit for vitamin A. And they had pretty decent evidence for vitamin A for the RDA, but for the EAR, I wanted to just point out, they used 13 individuals from 4 studies to develop the national EAR for vitamin A. Most of it was conducted on men. They were not able to support a different EAR for men and women because they didn't look at women. The historic studies that have been done in the 60s and 70s looked at white men. And so they just had to blanketly throw men and women together, and they had to extrapolate the pediatric recommendations from adult data because they didn't study kids back then. And even though these were 2001, so much of the baseline studies that have been done on vitamins and minerals in humans are pretty old because frankly, people aren't interested in doing those studies now because they're really difficult and expensive to do. And that's vitamin A, an area that has a lot of literature. If you look at the B vitamins, there is very little data. We're talking like the recommendations that we look at for all people for B vitamins are sometimes based on 7 adult young men, and that's it. So keep in mind that vitamins and minerals are a very nebulous area in general, and we don't really have any magic numbers even when we're comparing to the regular population. So we have, had studies specifically on renal disease and some of these topics that then help us highlight, but the problem is these studies are expensive and not easy to do. Like with B vitamins, it's really hard to separate them from each other. So we're probably never going to get great data. So that means that we really have to use our clinical judgment in thinking about some of these topics. So let's delve into renal disease specifically. Way back, in fact, one of the earliest papers I found, I actually, for my program at Rutgers, dug into vitamin A and renal disease a little bit more thoroughly, and the goal is to publish the paper with, all the extra time I have. But what's one of the earliest papers found actually cited a case series that you can't even find anymore from the 1930s, 40s, noting that even way back then they found that vitamin A levels could be elevated in excess. And what happens in healthy people is that you urinate out the excess, but even in healthy populations, if you have a massive dose all at once, you can develop hypercalcemia. And so this has been exemplified in CKD because we can't excrete the extra vitamin A. Especially cardiovascular complications likely related to that hypercalcemia. And so the first adult paper looking at this in renal disease that was really published and easy to find was in 1979. And then there were 4 papers in the 80s looking at adults. There were small studies that showed hypercalcemia with excess vitamin A intake. And typically it was somebody was taking a cod liver oil supplement, for example, that they were getting a lot of that. But interestingly, and I'm going to bring in my pediatric background here just because we had a unique population that kind of brought this out, there was a study in 2015 looking at vitamin A in pediatric patients because so many of our patients, especially our young patients, are on enteral feeds. It takes a long time for our babies to outgrow needing formula because there's a lot of reasons that they delay oral skills in that population. And so they found with that paper that 94% of children stage 2 through 5 had elevated vitamin A levels. And the further you got with CKD, the more you used enteral formulas. So especially our dialysis patients were showing signs of hypercalcemia. And because of that paper, then there was kind of a flurry of papers, a flurry for pediatrics, looking at vitamin A and showing a pretty strong association, anywhere from 92 to 98% of our patients over the spectrum of CKD had elevated vitamin A levels. Now, this really didn't matter to a lot of patients. They just sort of hung out at elevated vitamin A levels. But with a prolonged elevated vitamin A levels, and especially those who are enterally fed, we were seeing some hypercalcemia. And I think that's now kind of a bigger topic that we address in the world of pediatrics. And so what did we do with this on the task force? We suggested that the intake of vitamin A, where accumulation should occur, should not exceed the DRI. We suggested that there be biochemical assessment if there were signs and symptoms of deficiency or excess. Deficiency if you have wound losses or whatnot. But some symptoms are unexplained hypercalcemia or elevated intracranial pressure. When is modification indicated? We should not be giving our patients vitamin A supplements. And I think that's because of the evidence we had in pediatrics, we were a little bolder to say, do not give a supplement with vitamin A. And really, we're not worried about our oral eaters, that they have the least incidence of this. But if you have that off family who's giving their child or an adult a cod liver oil supplement or eating liver regularly, no kid I know eats liver regularly, but if you did, that's what you would do. So the take-home message from this, and something that I think can apply to adults as well, is if you do have somebody who's kind of on a crazy supplement plan and taking cod liver oil, that you should be considering risk for hypercalcemia. And if you do have patients on enteral feeds, you should probably pick a formula that's a little bit more moderate in vitamin A as opposed to one of the formulas. A lot of the plant-based formulas are really high in vitamin A. And you can consider vitamin A when hypercalcemia is unexplained. So I'm going to go through the other 2 fat-soluble vitamins really quickly because they're not as intense as vitamin A, and then I'm going to turn it over to Molly. So there's a lot of mixed literature on vitamin E, and general health recommendations for CKD recommend avoiding supplementation. There's a little bit of evidence saying that if we have a lot of oxidative stress, we could consider it, but the majority of the evidence really lean toward our patients have high levels, probably not overly troublesome. So take-home message, don't supplement with vitamin E. If you have tried everything to manage anemia, this could be an option for oxidative stress. Vitamin K, most of the literature in the adult world is actually in bone and cardiovascular health. But when Molly and I were comparing notes, one thing we found was that there's evidence, or not even evidence, there's hintings of this, but no solid evidence of the role of vitamin K in cardiovascular or bone health. that may be an emerging topic. There's very limited evidence in children, and what there is actually in children with any kind of medical processes going on, and the use of over antibiotic use. And a big study showed that children who were chronically on antibiotics were sometimes showing some deficiencies of vitamin K. I actually had a patient who had peritonitis, and we did repeat antibiotics, and she had clotting and bruising issues, gave her a round of vitamin K, she got better. So take-home message would be maybe think about this if you've got patients on a lot of antibiotics, like you would think about it for any human that is on a lot of antibiotics. So actually, I am doing the next part just to lead into our next topic. Assessment and management of vitamin and mineral status. Again, only when there's signs and symptoms of excess or deficiency. And then you can kind of see the summary of the statements here. KDOP 2020 is also enforces that we probably shouldn't supplement, but I would say the statements are a little less strong than what the task force does, and that K and E are not typically recommended because, again, they're fat soluble. So our next case, a 75-year-old female on hemodialysis due to history of hypertension. She develops pain with eating and bleeding gums. What steps would you consider for evaluating this patient? So consult with dental, 3-day diet history, evaluating labs, including serum vitamin levels, or all of the above. So I would actually argue that you would start with the 3-day food record. You might eventually get to dental or doing labs, but we would probably just look at the dietary history. So that is what was done with this patient, and determined that diet was primarily composed of white rice, small amounts of chicken, and cookies. She liked her snacks. So what steps would you consider for treating this patient? And don't be alarmed by our number of slides. Some of these slides are for reference for you all that we are going to skim through very quickly. We figured you'd rather have the content that you could look at later than us talking about it all day. Okay, I'm just going to jump to it. Coach on high vitamin C rich food intake, 100% agree. And probably if there's, because of the state she's in, starting a water soluble vitamin, especially if she doesn't have a good intake, is also pretty reasonable. Because clearly very poor vitamin C intake. So our next case, we have an anuric 4-year-old male on PD with a history of congenital anomalies in the urinary tract and kidneys, also known as CACUT in our world, congenital anomalies of kidneys and urinary tract. Has a distal femur fracture. 6 months later has a radial and ulnar fracture after falling on the right arm. Serum phosphorus, calcium, vitamin D, ALK Phos, and PTH levels were treated appropriately during this whole time, and around the time of the injuries, both labs were pretty much within normal limits. So what would you consider evaluating for this patient? We're giving away our answers because I keep saying need to evaluate as a dietitian, evaluate the diet of the patient. So yes, we would probably start with a 24-hour diet history or recall, and then you could potentially move to some of these other things as well. So just a brief history, the diet recall demonstrates enteral formula use plus fortified juice intake plus water-soluble vitamin supplementation. So they've been blanketly put on a water-soluble vitamin like we do many of our patients, and then that's the rest of the intake. So what would you consider treating for this patient? What would you think based on the clues we've given you? Okay, so certainly bisphosphonates could be considered with the team, but what ultimately was done was the water-soluble vitamin supplement was stopped, and actually their enteral formula was reevaluated as well. So this leads us into our discussion of water-soluble vitamins. I'm going to talk about C, and then Molly will be going into the B vitamins. So this is my last slide before Molly chats. So vitamin C is a very controversial vitamin. Studies are mixed in terms of how much vitamin C is lost through dialysis, and that is adult and pediatric studies, especially adult studies. There's more of them. So historic studies on oxalate-based kidney stones, and one recent pediatric study, it had small numbers, but it was considered pretty significant for our development of the guidelines. And that is because they were able to show that several patients were developing some oxalate crystals that were affecting their bones. And that's especially important in pediatrics. When they're still growing, it might affect them more. But these patients were being so supplemented that it was determining that the vitamin C was contributing to oxalate-based kidney stones, especially since the vitamin C DRI is lower for children than it is for adults. Molly is a CKRT expert who could talk to you more about mixed results with whether we supplement in CKRT where we know losses are greater. But the take-home message that again you could think about for your patients is that vitamin C may have a sweet spot. In our pediatric group, we said no more than 250 milligrams. I would say for adults, from the literature I've read, 250 to 500 is that max you want to hit. So that you have a lot of patients that take a lot of vitamin C fortified foods or think that vitamin C is pretty benign. But there have been reports of oxalate-based bone damage. So again, looking at your physical exam could also be pretty important. So I'm going to turn it over to Molly now.
So just to start, I am a little opposite of Chris. She always wants diet first, and I'm going to always say physical exam first.
That's fair.
Okay. So no more diet recalls in the polling. Don't worry. Okay. It's feedback. Okay. All right, so I'm going to talk about B vitamins in a group because it's similar to what Chris is saying. It's very hard to separate them. But in general, what you'll find in the literature is there's very limited evidence to support that B vitamin supplementation actually improves outcomes even for dialysis patients. And it's a little unfortunate because it goes against the grain of what we usually think. And for the most part, when these recommendations and these clinical practice points are made, both in KDOPI and in the PRNT, it's really focusing on clinical judgment, individualized assessment, because there's so many confounding factors. Because when you do nutrition research, there are a ton of factors to control for that you just can't. So I'm going to start off with biochemical assessment of vitamin status when we're talking about water-soluble vitamins, because Chris kind of introduced a little bit of those other points. So, and we start off here, and I'm an advocate for physical assessment primarily because I think when we're talking, diet assessment and physical assessment, when we're talking about being in the real world and clinically assessing a patient and saying what you have time for and who's willing to draw what labs, and then training dietitians to do the same, it becomes very difficult. In my experience, it's very difficult to train clinical judgment. And again, a lot of what this talk we hope to focus on and get you guys to take away of is having a framework for developing that clinical judgment and systematically going through those check boxes. And so when it comes to most of these, when requesting biochemical assessment is kind of an afterthought. You have more of like a risk stratification that you go through. So in this example for water-soluble vitamins, anytime you have unexplained macrocytic anemia, and you've gone through those two top diet assessment and physical assessment, then your next potential ask is to get water-soluble vitamin labs, whether that's folic acid or B12. And then you're talking about what risk factors does my patient have? Are they on peritoneal dialysis? Are they on hemodialysis? Are they taking any medications, there we go, that will interfere with vitamin and mineral absorption? So there's specific nutrients, water-soluble vitamins, that are more lost in peritoneal dialysis in the literature, that's been reported in the literature, as well as those that are reported to be at higher losses in hemodialysis. And then, of course, you always have to think about, and we'll point out with each of the biochemical assessments for these remaining nutrients, which ones you really need inflammatory markers with, because they will be affected by inflammatory markers. Many of these other trace elements are also acute phase reactants. So you really have to use these two things in the context of the patient. So where to next? What do we do with an intervention? If your diet is low, we recommend supplementing. And then if you have a particular patient on whichever form of dialysis and your intake indicates it's deficient and your physical exam indicates there's a deficiency, then we recommend supplementation of those particular nutrients. And then again, also thinking about that assessment piece for medication interference. And then supplementing folic acid and B12 together, because you don't want a masked deficiency. And then Chris already hit on the vitamin C. So when you look at the KDOQI 2020 guidelines, they kind of still recommend supplementation for anybody with inadequate dietary intake. And those outcome assessments that they looked at for your water-soluble vitamins, particularly folic acid, there was actually one of their big questions was, does folic acid supplementation help in CKD patients with hyperhomocysteine? And there was no evidence to support that it did, unfortunately. But that doesn't necessarily mean you don't need to supplement it, especially if you are using a risk stratification assessment framework. Let's see. And then similar to vitamin C, as we did in our pediatric recommendations, adults, again, similar recommendations for like a nice little sweet spot, don't exceed high levels for that oxalate. So being in pediatrics and being on this task force, when I read through the 2020 guidelines, I found it a little bit irritating. I would say it nicely, because I don't have a lot of time to go through and look through a bunch of different little papers. But what they do is actually, there is a secondary paper for the KDOQI guidelines that talks about supplementation, completely separate from its own, from the guidelines. And I found that's the piece that I found a little bit frustrating. But, because I like a one-stop shop, you know? What they did do is something similar that we have on our guidelines, is they're actually taking DRIs and then the European guidelines and then what the KDOQI guidelines had, and they're kind of, then developed the KDOQI consensus and did a very similar approach to what we termed our SDI, where they came up with, this is the range that these adults need from a supplementation or intake standpoint. And most of the time when you're looking at the vitamin A is the same, recommendations the same, vitamin E is the same, and they're actually recommending the higher end of most of your water-soluble DRI intake levels, just to kind of cover some of those water-soluble losses that you may have in your higher risk patients. So when it comes to water-soluble vitamins, I really want you guys to think, or really any vitamin, I really want you to think about risk stratification, risk identification, then risk stratification, because you can't just always, it's very hard in practice, in clinical practice, to just go back to, well, there's no RCTs, so I shouldn't do anything, right? You can miss the point there. And there's plenty of observational studies that do show Patients lose water-soluble vitamins in dialysis. They have lower intakes as they progress through CKD. And when it comes to water-soluble vitamins specifically, they really have a pretty low toxicity risk. And so then it's that risk versus benefit situation that you also see throughout the adult literature on, do I want to increase pill burden or not on these patients? What's the benefit here? And then, of course, targeted monitoring for at-risk patients. Okay, so we are not going to do a huge review on bone health because it could be in its own talk. But we want you.
Publish separate papers on that as a task force.
We want you to have the information readily available as a resource, and so that's what we've included in these slides. We know that bone health is an extremely complicated topic when we're talking about CKD and dialysis. So here are the KDOP 2020 guidelines. Supplement when you're deficient on vitamin D, and then calcium, phosphorus. You want to maintain the appropriate intake, but restrict if you have to, and then supplement post-transplant if you need to. Similar stands for pediatrics as well. I'm going to go through just to maintain time. In pediatrics, we did make a few poignant position statements about acute severe hypercalcemia, and that requires that's life-threatening and requires rapid medical intervention. Let's see. And then if you have mild to moderate persistent hypercalcemia, a stepwise approach to addressing that as well, because we're so concerned about bone growth in our pediatric population. Okay, next. So case study. Is this mine or is this yours?
It's yours.
Okay. No, it's,
This was actually based off a case that was shared at another conference.
do you mind passing my water? Okay, so it's a 3-year-old female with renal dysplasia on PD with diluted Saplina. Yes, we still use adult formulas in pediatrics because there's not a lot of other options. Given through G-tube, the patient presents to clinic with worsening fatigue. On exam, they have a poor response to deep tendon reflexes, slightly low blood pressure, heart rate, and breathing, but a normal EKG. What steps would you consider for evaluating this patient? I also think on initial evaluation, a lot of times you kind of guess until you see one of these cases and you immediately always know. So, lab results included an abnormal MAG of 6.2. So, what steps would you consider for treating this patient? Yeah, I would.
Sorry.
Oh, that's right. Okay. So either of those two are very good thoughts to address. In the pediatric world, I think we tend to see this a little bit more frequently, and you'll kind of see in some of why our some of our recommendations. I also, so this was Chris's case study. I have my own case study, and I was actually. We actually have a hospital admission right now for a magnesium of 6.9. I've already switched the patient to a lower magnesium formula, so I have problems. But anyway, another sign of membrane failure, if you want to look at that. All right. So what does the literature say on magnesium? As you progress through CKD, urinary magnesium excretion decreases. With proteinuria, you may have increased magnesium losses. PD and hemo, you have to take into account potentially the magnesium source of dialysate fluids and blood that will then determine removal. So in our experience, we see more hypermagnesemia with peritoneal dialysis. And then there are also, of course, medications. There are medications that increase losses. There are medications that decrease absorption. There are medications that contribute to intake. And then, of course, this is a common medication that you will see in transplant patients. Your calcineurin inhibitors then lead to magnesium wasting, and you usually have to supplement those patients. Overarchingly, what does it look like when you have a patient with hypomagnesemia? Those patients tend to have a higher risk for cardiovascular disease, higher mortality, risk of muscle cramping, and then you have both low mag and high mag can also be seen with bone disease or dental calculus formation. Dietary magnesium, higher dietary magnesium is actually associated with positive outcomes with growth, fat mass, overall nutritional status. But we know that our patients with kidney disease usually have low magnesium intakes. If you think about your food sources of magnesium, I don't have a lot of patients eating a bunch of nuts. And then blood concentrations aren't necessarily always reflective of that dietary intake, which kind of goes back to the point of really look at those medications as well. When you look at studies on supplementation and increased serum concentrations, especially in vitro studies, you actually have a decreased risk of vascular calcifications, cardiovascular disease, and all-cause mortality and inflammation, with also reported improvement in glucose and lipid metabolism. So clinically, what does that look like for the dietitian? Here's your risk stratification, right? So we want to, if you don't normally check levels, you may want to look at your risk factors for high and low concentration. So patients with hypokalemia, hypocalcemia, on certain medications, i.e. like calcineurin inhibitors, and then supplementation should really be based on your laboratory values, right? So once you start supplementation, you really have to monitor it. When we talk about transplant, that supplementation can cause some GI side effects, but there's also an opportunity to attempt to educate on diet and see if they can improve their intake that way. Let's see, I already kind of talked about those. So practically speaking, we deal with a lot of really high magnesium levels sometimes. And so one of our big questions that we had in our pediatric nutrition task force was, what level is too high? Because we know we have our patients that hang out in the 3s and 4s, and is that okay? And actually, there's a lot of good adult literature that says it's actually fine. It's quite cardioprotective to, as long as the patient is asymptomatic, 2.5 to 5.3 is okay and well tolerated. But when you start looking at supplementation for low magnesium, you're looking at moderate to severe levels, and then looking at other ways to adjust magnesium intake or other medical reasons for hypermagnesemia. Once you get into your moderate to severe levels, that's kind of where you start making those interventions. But a good piece of this is always to think, well, do I have to react to this level kind of thing? Because I will say even my physicians sometimes aren't sure which level they're supposed to react to.
We typically did above 4-ish.
Yeah. Now you don't have to do it until 5.3.
I'm popping up just to do the next case study because it was my patient, and then Molly will take it away. And that last one actually wasn't, the magnesium wasn't my case. It was somebody else's case, but a pediatric patient. So this case study we want to do now is a 20-month-old with posterior urethral valves who's on PD. Their local dentist wants to give fluoride treatment due to no fluoride content in the local water. So what steps would you take to evaluate this patient? What key considerations would you have? Intake, signs of deficiency, fluoride levels, toothpaste type, physical exam, diet recall, current intake. Good words, good words. Toothpaste, diet recall, current intake. Okay, I'm going to move on. What steps would you take to evaluate this patient? What are key considerations? Okay, I'm gonna go with all of the above. Really, this child's clearance, whether they have any urine output, makes a big difference. We do want to be thinking about fluoride content of the water. There is one of the papers we used for our task force guidelines is a recent paper on NHANES data that did show that areas, even in the US, with the highest fluoride content in the water had some lower GFR levels. So I'm not anti-fluoride. In fact, I don't have fluoridated water and I get fluoride treatments regularly because when I don't, I get cavities. But I think, again, it's that sweet spot, it's that balance. So what would you decide to do? Okay, and I'm just going to mention that what we did was 100% not evidence-based. It was pure clinical judgment because we had no precedent for this. We gave a quarter fluoride treatment to this patient. We decided that since now he was on PD, he did still have urine output because being anuric makes a big difference there. But with zero fluoride, or very, very minimal fluoride content of their local water, we sort of decided to split the difference, but knowing it accumulates and that it accumulates as early as CKD stage 2, and this is a big time pediatric issue because it affects pediatrics more because they're developing their teeth still, but it could be an issue for adults as well, especially with excess fluoride intake. So one thing, a quick review of literature, and we included this just because I think it's kind of a unique thing that the task force looked at. Most of the literature is in pediatrics. We only found 5 studies. So again, one could argue that maybe we shouldn't have made statements, but we're like, we need something for clinicians to actually think about and do in this area. So especially in some Asian countries, they have very high natural fluoride content in the water, and the incidence of CKD is higher in those areas. Tea and coffee, not just the water intake, but tea and coffee themselves have fluoride intake. So if you've got big coffee drinkers, that's something to keep in mind. And children with impaired kidney function have even poorer excretion of fluoride than adults. So because they have the poorest clearance, it's definitely a pediatric issue, but I don't think it's something that you can rule out for adults if you, again, have an excess coffee drinker, if you live in an area with high fluoride content. So think about the water content of your local area. Think of it as one of those one-off cases. When you're once in a career cases where you cannot figure out what is going wrong with your patient. These are the type of considerations that we're putting out there for you all to just have in the back of your mind, the back of your pocket when you encounter weird stuff. I would avoid fluoridated products. And especially if you have polyuria, polydipsia, again, more of a pediatric issue, there's a greater risk. And we really need more research. There's such little research, but given how serious this could be, I think this is definitely an area for research. I'm going to turn it back over to Molly to finish us.
So you may think it's crazy that we're talking about tea, like excess tea. And we've had these discussions. Like we argue about these statements for months. And then I thought about, like, I'm in the South, like Texas, sort of South. But, you know, we do a lot of sweet tea, okay? And then I was like, well, okay, I guess this is international. Okay, I'll allow it. All right, so case study, the next case study, 5-year-old female ESRD. So this one, again, this is a pediatric study, but I found plenty of other case studies in the literature for adults on this one too. So 5-year-old female with ESRD due to bilateral renal hypoplasia on CAPD since 2 years old, primarily tube fed with a medium chain triglyceride-based formula on multivitamin, trace element supplement, zinc, iron, and folic acid. She developed progressive anemia with anemic symptoms, hematocrit decreased from 34 to 25.8, and is on sub-Q ESA injections 200 to 250 units per kilo per week, which is quite high. What key questions or clinical measures would you ask or decide to investigate? All good thoughts. Okay. So, the first thing we usually do in pediatrics is check a stool cold. It's negative. But the patient requires a blood transfusion, right? Got to treat it. 2 months later, hematocrit drops to 18%. They went as far as a bone marrow biopsy, which was negative for anti-erythropoietin antibody, but the biopsy was consistent with hypocoupuremia. So, what's your next step? Yep. Yes. Yes, I'm going to go check a copper level. Copper level was low. Still weird, right? Like how often do you see a low copper due to low intake? What was also done was checking a zinc level. High zinc. All right. Make sure I got my notes. So what happened? The patient was diagnosed with failure to thrive and had a minimal amount of zinc in her special diet. This resulted in a prescription of 20 milligrams in elemental zinc sulfate to improve growth. However, these are the results of unintended consequences where levels are not routinely monitored. So excess zinc intake led to copper displacement of excretion via stool enterocyte shedding. An adequate copper level is required to actually transfer iron throughout the body. And so she was anemic, but due to zinc supplementation because it interfered with copper. So supplementation was stopped, copper levels spontaneously returned to normal, ESA was started at a lower dose, and hemoglobin returned to normal within 2 months. The summary here I like to usually point out is that zinc sometimes, similar to some of these other vitamins, kind of seem innocuous, but it's really not. It can have negative consequences too. So if you're going to supplement, you need to monitor levels. So when we look at zinc literature, zinc excretion decreases with a decreased GFR and decreasing urine output. But historically, when you look in the literature on dialysis clearance of zinc, you get really mixed results, primarily because your historical literature on zinc clearance had to do with water contamination of zinc. So if you had less clean water, you would actually gain zinc with hemodialysis. So these patients historically were not deficient. However, more recent literature kind of points to some of that maybe not being much of an effect anymore, and how some water guidelines and quality guidelines have improved at this point. You also continue to see low intakes, most specifically with dialysis, then CKD, then transplant, and then healthy individuals. Zinc we know is protein bound, so if your patient has proteinuria, that's a concern. It's a risk factor in malnutrition. If you don't eat enough protein, you likely don't get enough zinc. Blood levels, we also know that blood levels don't necessarily reflect whole body stores. As an acute phase reactant, it can have tissue redistribution to the liver, and so what you're measuring may not be what it really is functionally or from a storage perspective. And then what I also found interesting, because something that is taught time and time again is that you will see taste alterations when you have low zinc. However, in the literature, this was not, when I reviewed, I had zinc actually. When I reviewed it, it was all over the place, whether or not it actually improved taste sensitivity. And again, you have that competitive binding with iron and copper, so you have to be careful. So when we look at that clinically, in all of our trace elements, when you have poor growth, yes, we can look at zinc, but you have to be careful to not just start zinc, but also monitor it if you're going to give a supplement. Then, if you are giving iron and zinc, you have to give them apart. You can't give them together. Similarly, you have to watch copper. So just supplementing one nutrient kind of opens up a bit of a can of worms here. I'm not saying you shouldn't, but these are logical steps you kind of have to look out for. Specifically in pediatrics, we have to look at nutrient excess. So in one of our case examples, you saw that a patient was on an adult formula. This is largely what we had to do quite frequently in the past because that's all we had. And so they were at risk for extreme toxicity for a lot of your trace elements. And then the same thing with proteinuria for all of your trace elements. And then those receiving hemodialysis, you see a little bit more risk for deficiency for selenium, zinc, and copper. So again, you can supplement, but you need to really watch out for signs and symptoms like ESA-resistant anemia, and then start thinking about zinc and copper. Assessing overall intake before considering supplementation, looking at any oral nutrition supplements or age-appropriate formulas that you're thinking about. And when it comes to zinc, it's also where else are they getting zinc? We looked at diaper cream. We didn't really see any evidence of that, but there is evidence on denture cream, because that does have zinc. So we didn't include it in our piece, but in denture cream, there is evidence that it can cause high zinc. Okay, the remainder of the trace elements. Copper, mixed data, but the dietary intake is usually within the reference range for CKD patients. Again, the same problem with shared intestinal transporters, and it's also acute phase reactant. Again, we don't recommend monitoring levels, except in the case of unexplained ESA-resistant anemia and if you're giving zinc supplementation. Iodine. Iodine stores increase, iodine blood levels increase with decreasing GFR and urine output. It's found in PD catheter cleaning supply solutions, and if you use it in hemodialysis locks. And it is a cause of goiter or hypothyroidism. So we actually recommend that you consider assessing levels. You clearly have to do it mostly in the blood if your patient doesn't have urine. But if you have a patient with unexplained goiter and hypothyroidism, checking thyroid levels. And then restricting supplementary intake of dietary intake or cautious handling of exogenous sources like your cleaning products. And then in this particular one, it was a very strict statement about seaweed, which was news to me. Okay, so selenium, lower levels usually, lower or similar levels compared to healthy individuals. It is protein bound, but no measurable losses in dialysis fluids. And again, also an acute phase reactant. So if you are looking at any of these, when you have an acute phase reactant, you have to also get like some sort of inflammatory marker at the same time if you're going to check these. And then actually in transplant, MMF is associated with lower concentrations, likely related to some higher GI losses. So clinically, we kind of hit that risk stratification of your nephrotics, tend to have lower levels. Think about that if you need to, but no specific indications for actually measuring these levels, check inflammatory markers, and really just achieve normal intake. Randomly, we still include manganese and chromium. These were found to have high serum concentrations in CKD and dialysis. I actually don't think there was any pediatric literature on these. It was so scant. But often seen, so with chromium, you often see it with water contamination, high levels, and then there are no losses through dialysate, and adverse consequences have really not been reported. Although this was an interesting topic because I know it is occasionally used as a supplement for diabetes, and that was really hard to parse out in any of our statements, so we made none. And then manganese, there's a lot of conflicting data on serum values. It is also an acute phase reactant, but there's no specific indications for measuring. And so realistically, it was the discussion that if measuring, like we had to talk about a lot of, if you decide to measure, what do you measure was another big common conversation. It was, so for manganese, use whole blood, but then also for and chromium, you have to like send out to some special lab that's, I think there's only 1 or 2 in the world, something crazy. So don't do that. And then supplementation not recommended because there's, but at the same time, there's no evidence that a multivitamin with those should be avoided. Here's your KDOQI for selenium and zinc supplementation, not routinely recommended. They actually made no statements on magnesium, even though they had a question on it. And then this is just a review of a lot of the things I kind of talked about, looking at that risk stratification. If you're going to ask for a biochemical assessment or a laboratory assessment on how to do it, if you think, if you need for one for iodine, copper, zinc, also your other risk factors that we kind of already reviewed a bit. Let's see. And then for intervention, same thing with like the seaweed co-administration of supplementation and watching out for and restricting with restricting iodine when excess-induced thyroid, there's iodine excess-induced thyroid dysfunction. Let's see, and those were our magnesium statements that I kind of already reviewed over anyway. Okay, so strategies for individualized care, because this is how you do clinical judgment. So you have to take everything that we've kind of talked about, the literature, the guidelines, integrate that into your clinical decision-making by having this stepwise pattern of investigation. Use these tools to show how you can use, and these resources to then develop potential interventions and assessment techniques for yourself and what works for your patients to really manage their full spectrum of needs. And then also utilize prioritization. You only have time for so much in the day. What's going to be the most efficient thing you can use? And so that's generally why I avoid diet recalls, to be quite fair. And then you can get a lot of data overload versus clinical relevance. Like, you know, you can, a lot of things can be told to you, but is it really relevant to your current practice? And then also think about balancing your interventions, risk versus benefit. And then applying that clinical judgment, when do you intervene versus when do you monitor? Well, you can monitor, sometimes these mild asymptomatic variations may self-correct. If these trends progress, you can adjust. And then when there's clear deficiency, toxicity, or symptoms, or patients who are high risk for these imbalances, you can intervene. But for the most part, it's really about recognizing that clinical practice evolves. Historical concerns may shift with emerging evidence. There's not a lot of evidence here, but if you can stay critically engaged into these guidelines and how they were developed and understand the basics for them, then you can start to apply them to really assess that risk versus benefit, your unintended consequences, recognizing these patterns to, again, point to some of those more nuanced cases where you're not sure what to do with this patient kind of stance, and then differentiating between individualized needs, whether they're pediatric, adult, or specific comorbidities that may raise questions, and really looking beyond those single values and trending, and really understanding that these, your patient's nutrient status is dynamic. It's not static. It doesn't, if you do it once, it doesn't mean it's not going to change. So thank you for your attention. This is our a small portion of our PRNT group.
In the UK for our meeting. We note.
We actually have several questions. We'll get started. I understand if people need to leave, but we'll go down the list here.
And Molly and I are happy. We know that we push time, so we're happy to stick around to, answer questions later if needed.
Several are asking for clarification why excessive vitamin A causes hypercalcemia.
It is because vitamin A increases osteoclastic action in the bone and decreases osteoblastic action. Retinol has that impact on bone, and I won't give you a whole biochemistry lesson, but that is the synopsis of how that works. So when you run elevated vitamin A levels chronically, you're breaking down more of your bone. bad for cardiovascular disease too.
How soon should lab markers be drawn after diet changes or supplementation to address deficiencies have made? Should they be drawn more frequently after?
I would say it depends on the nutrient, but the longest time I think you would need to go is probably like 2 or 3 months. So particularly for trace elements, it's usually about 2 or 3 months after supplementation has started.
And you're also welcome to come to the microphone to cut the line.
All righty. What formula is lower in magnesium than Soplena?
Soplena is an adult formula, and so that was why many of us had trouble with magnesium in many of our young patients where the DRI is lower. A lot of our pediatric formulas, and I hate to use commercial names, but there is a formula that Rena Step that was created for pediatrics, but I know they're branching into the adult world as an oral nutrition supplement, and that was designed to be a little lower for magnesium, I think because it was originally developed for pediatrics. But honestly, if you just look at different formulas, they all kind of vary, and you would just probably pick a lower mag one.
I would say I've had a patient whose MAG has been in the 8s, and I treated him with an infant formula, and he was not an infant.
Go ahead.
Hi, I have a question regarding vitamin A dosing. I'm working in hemodialysis, and I encountered vitamin A deficiency in one of my patients, actually. Prior to my work with her, because she had short bowel syndrome. Anyway, so I did a research into all this, and I realized or understand that sometimes it was falsely elevated, the vitamin A or the retinol binding protein. So I just want to clarify with you, because it seems that we can just like dose it and that it's a valuable value, I guess. So what is the difference? Like, is it retinol itself or retinol binding protein, and is it reliable? That's mainly my question.
So typically we use retinol. I love Molly's input too, but to be able to assess it. And there is some difficulty in CKD because of the retinol binding and whatnot, but typically it is pretty reflective, I would say, and absolutely I would just feel comfortable giving a regular vitamin supplement, potentially with additional supplements for other losses, because some of those needs might even be greater than vitamin A. Molly, any additional thoughts?
No, but I know what you're talking about. I haven't looked into the vitamin A literature as much as Chris has, but I know definitely if your retinol binding protein is not high, I would question. I would think that that's more of the indicator when it's falsely high. When your retinol is falsely high and then you don't have the binding protein to actually bind it. That would be, I think, more of the idea that you're getting
So
at.
to dose the two, like the retinol and the retinol binding protein?
No.
Sorry.
It's more of like, to me, that's an indicator of activity. So like, can it actually get to the cells it needs to? If you have adequate binding protein. If you do not, I would expect that it cannot be used as well. Okay. And so I think that would be more of my concern. Like, I wouldn't have as much of a concern with a high retinol level and a low binding protein.
All right, thank you.
Question?
Hi, my question is related to, you talked a little bit about vitamin K deficiency and the use of antibiotics in peritonitis. I guess I'm just kind of interested in its association with adults, maybe in-center patients with catheter infections and frequent use of IV antibiotics in that population too, especially given that a lot of patients, there's a lot of talk about vitamin K supplementation. So I just wondered if you could elaborate a little bit more on that.
So what's interesting about vitamin K is it does rebound pretty quickly because the gut makes it, but when we wipe out our gut bacteria, that we see sort of an acute issue. And I think you just have to think about the clinical implications. So is your patient going to bounce back quickly enough that you don't potentially need to do a vitamin A or K course? In our case, this kiddo had some pretty significant bruising and difficulty clotting after labs, so we did do the vitamin K course. But I think it all boils down to their clinical symptoms, because we know we wipe out vitamin K after antibiotics, and in healthy people it rebounds quickly. But if you're doing repeat antibiotics for catheter infections or whatnot, and you have the potential of keeping them kind of suppressed for a while, that's the concern. I would base it on bleeding risk, bruising, clinical symptoms.
And I think right now the best way to measure vitamin K status is actually
INR.
not clinically available. And you're just looking at PTTs.
Yeah, we don't even draw vitamin K. We look at PT and INRs and whatnot.
Okay, one more ranked question. How often do you check zinc levels when you supplement? Do you also check an ALK phos, since serum zinc levels are not always reliable?
The 2 to 3 months for the first question. ALK phos, at least in our institution, it's very difficult to assess that in a pediatric patient because there's so much of it that's bone related.
Growth.
And as your patient's bones grow, so do their ALK phos change. And if anytime you are trying to treat osteopenia itself, it will also change. It initially will go up before it goes down. So it's really hard to say if that's actually contributing to the zinc status versus just having potentially a CRP or something like that.
And we have a question about a case study clarification. Why was the water-soluble vitamin stopped in the case study with the fractures?
Oh, because the bone damage, they actually in this paper talked about how they did like a pretty extensive bone study, which you wouldn't typically do in most clinical practice. But they were curious why they had these patients with fractures. And so they did bone biopsy and found oxalate damage. Vitamin C can promote oxalosis production in the gut, and so they had oxalate masses in the bone material of this patient, and because they were getting a formula with vitamin C and they are drinking this vitamin C enhanced orange juice, which I believe they also told the patient to stop, and they were getting a standard water vitamin supplement, they needed to, they weren't probably going to change the enteral formula because the kiddo needed that, but they got rid of the surplus sources of vitamin C to reduce the risk of gut creation of oxalate.
Is it recommended to still leave out chromium and manganese from the TPN for renal patients?
It's Molly.
That's a Molly question.
She's TPN expert.
I don't know that I'm thinking at my facility, there's no special, I avoid it. I have my standard trace element and multivitamin. If it's excessively difficult to remove items and then add them back one-on-one, I don't bother. Until they make a renal specific product.
Okay, we have one more question and then a comment. Are there any developing guidelines or differences in assessment and supplementation of vitamins, minerals for patients on extended CRRT therapy?
Also all Molly.
Say the question, sorry.
No, that's fine. Are there any developing guidelines or differences in assessment and supplementation of vitamins and minerals for patients on extended CRRT?
So the AKI guidelines that we have from a pediatric standpoint were
she was
actually
lead on.
the impetus, the start of the vitamin and mineral and trace element guidelines because they developed this table and they thought, oh my God, this is a lot of information, and then decided that we had to break the next topic up into two. Fats like your vitamins and then your trace elements. But anyway, those are the most up-to-date guidelines for that. We do allude, I feel like we allude to this in the paper, our guideline paper, that, you know, when you look at, even in most of your literature is in the adults, when you look at patients who develop severe deficiencies, it's the ones that are, it's that risk stratification, the ones who are on CRT the longest, and then if they have any additional comorbidities that contribute to higher need or higher loss. So there's there's a couple of case studies in the literature that there's one from Sweden. Somebody develops life-threatening bradycardia from severe hypertriglyceridemia that actually ended up being a severe copper and selenium deficiency. The patient was on CRT for 200 plus days, but that's because they had like severe grade 3 burns over, I don't know, 90% of their body. And then they determined, and it was fixed with copper and selenium supplementation. But those are things that you don't routinely run into. So it's really that risk stratification of what you're seeing.
And then the comment, vitamin A toxicity is recently in the press due to unvaccinated measles children using as substitute for the vaccine. Hope they publish these findings.
I really do too, because even in healthy people, if you take a lot quickly, it can cause these issues.
Yeah. So thanks, Molly and Chris. We really appreciate your expertise in this area.
Thank you for your attention.